and Engagement, and Ali Roberts, who's the Associate Director of Systems Development and Strategy at the ICB. Thank you very much.
Lovely. Well, thanks very much for inviting us along to talk to this today. I'm not wanting to go too much off brief, but what Ali and I are hoping to do is I will give just a bit of an introduction really as to who I am and why I'm here and what my role is. Talk a little bit to our how the ICB really hopes to work with public engagement, public patient engagement, but then turn to Ali to do the more formal part of our presentation. We hope really, as would be overall our strategy for public and patient engagement, to listen more than we are talking, but human nature and an innate personality, we will try our best to do that, but that's really how we plan to structure things. So, and I apologize that I know that I'm speaking to some people who have been really intimately involved in the formation of the integrated care system, the integrated care board, and are Simon, Joe, members of the integrated care partnership, the overarching sort of umbrella. So forgive me if there are things that we say that you already are aware of. So I'm Sarah Raistrick. I'm by background, I'm a GP. I live and work in Coventry, so I'll put that out there now. I'm not someone who lives in Worcestershire. And I am the non-executive member on the Integrated Care Board for Herefordshire and Worcestershire. And my areas in my portfolio, whilst covering all things on the board, the areas that I have in my portfolio are health inequalities and public patient engagement and sustainability and the green agenda. So that's what I come to bring to the table and to the board. So in terms of the public patient engagement side of things, it's something that I personally am hugely passionate about, conscious from my work in general practice that we need to listen to the voices of people in our communities, and I work really closely and very involved in Healthy Communities Together and work with the King's Fund and the National Institute for Health Research on how we can actually quantify how we're listening to people, how we can have a bit of a research base to that, and how we don't just listen but then we put into action what we've heard. Also looking at how we work with more seldom heard groups, really interesting there that we've got co-opted members representing organisations working with homeless people, very difficult often to capture their experiences of service and needs, and when we do capture that, to actually make inroads in changing things, and people with learning disabilities, autism and other disabilities, especially hidden disability. So that is something that I'm hugely aware of, and the integrated care system is, and my role as a non-exec is to bring and champion that voice. And again, you'll be aware as directors of Health Watch that actually the role is about being on a board, it's about bringing that voice, and it's about not allowing that voice to go unheard. Now let me say, I work, this role is 3 days a month, and so I'm not a new member of the comms and engagement team, but I do sit at that board level and I am able to influence and to bring that voice. I'm making good efforts, and it'd be great to make further contacts with you in your different roles to really listen to people who live in Worcestershire, and doing that through, at the moment, quite traditional routes. So through visits to hospitals, talking to patients, visits to some of the work going on in GP practices, and through the partnership through WEC, and sort of listening to counsellors at the Health and Wellbeing Board. But I'd really like to acknowledge that the only way that I'm going to represent that voice is by listening to people who are working with people, who work with people, who work with people, so that really we don't miss anything out. And my plea really is that as part of my role, I want to be able to ask the right questions, to bring the right concerns to the board. And one of the ways that I'm going to be able to do that is if I am fed information, if I'm given local knowledge, so I will actively seek that. But I think if there are big issues that you're aware of, if there are things you believe are not getting heard, or if there are plans that you hear about that you think, hold on, how is that going to affect this group of people? I'm really hearing that this is causing concern for a community. I would love you to let me know that, so that they're questions that I can put to the executive and make sure that patient voice isn't lost. So that's the role that I have in terms of not formal engagement, but making sure that that voice is heard. Hope to getting to know Simon and Joe, but hoping that we end up having with Healthwatch a really positive relationship, that Healthwatch are present at so much and in so many communities, but actually it's not always appropriate that they're the ones that bring a question or a concern to the board. And I'm really happy to be that conduit, really, where appropriate, weighed up with all my non-executive responsibilities. I'm really keen to do that. So that's me. Health inequalities is a whole nother subject, but that is something that we are actively working with communities, with districts, and with places to make sure that plans turn into action and reality and improved lives for people living in our community. So I have a wealth of experience in that as a doer in Coventry and Warwickshire. So I bring that expertise here, but again, have to be really careful that I'm doing that in a non-executive role and not an executive role. So that's where I come from. That's where I fit into the ICB and the integrated care system in terms of the engagement and involvement. But for the more, I don't want to say the more corporate side of things, but from the actual director level, and the person with the slides is Ali, and I will hand over to her. But I'm really happy to take questions and feedback sort of at the end. Anything you want from me, any gaping holes that you've already seen since July when we started the ICS. I think bottom line, we're all in this together. We want the lives of people that live in Worcestershire to be improved. We want their health to be improved. And so we need to work together to achieve that. So I'll hand over to Ali.
Printing out all the new response plans. So next week I'll drop a copy over to Ali.
It keeps being muted. Is it something that we're doing centrally, do you think?
Sorry, Ali, I built you up there as our slideshow expert, and now I've dropped you in it. So let's see if you can.
Hi, Ali. I'm asking you to unmute. Okay, I'm going to ask everyone to unmute and see if that works. Are we all right?
Can you hear me now? My sincere apologies.
Yeah.
Fantastic. I'm so sorry. That was not a very smooth entry. I don't use Zoom very often, and my laptop tends to just get a little bit unhappy. So apologies for that, and thank you for bearing with me. Good morning. It's lovely to meet some of you for the first time this morning and to see some familiar faces that I will have crossed paths with in the past around various tables. I've already done introductions, but as Sarah said, my kind of core role in NHS Herefordshire and Worcestershire in the ICB at the moment is to really focus on working with colleagues and partners to develop an integrated care strategy for Herefordshire and Worcestershire, and also to think about that system development side as well. So in terms of actually what do we need to do differently, how do we need to work together, and what might we need to do to enable that around our collective aim. So I felt it was a really good opportunity this morning with the time that you've given us on the agenda and Sarah on the agenda to bring actually the kind of formal, what we're calling the phase 2 engagement kind of listening exercise with the strategy to you. So it's great actually, Jo, that we've got the kind of core directors and the co-opted members as well. So it's a fantastic opportunity. So what I'm going to do is talk you through a few slides if I'm competent enough to share them, which I believe I am. And then I will pause for any clarification questions if that's okay, Jo, and then I'll go to my kind of core, very open questions. And I just sort of from a scene setting point of view, you just say, I really want to hear your views and the views of kind of those people that you work with and that you talk to. So here we go. Can I share my screen? I'm feeling hopeful. Here we go. Right, if I just pop it into slideshow, then we might be on the road. I've just got to work out how I can do that, because otherwise I'm conscious it'll be a little bit small. There we are. Okay. Somebody give me a yes, we can see it, or a thumbs up. Thank you, Jo. That's brilliant. Thumbs up. Thank you for that. So I'm gonna dive right in. Jo, if I'm going into too much detail and you've already briefed the board, then just stop me and I'll move on with the slides. But I just wanted to start with reflecting on the fact that obviously the Health and Social Care Act, along with the transition from kind of CCG to Integrated Care Board, also instilled a fantastic opportunity for systems across England, which was to develop an integrated care partnership, and that integrated care partnership is a broader assembly in Herefordshire and Worcestershire, and the sort of core founding members of that are the ICB and are put down to be the two upper tier local authorities, so Worcestershire County Council and Herefordshire Council, but also bring in a much broader set of statutory and non-statutory partners, and I would say sector and community representatives. So Jo very kindly attended the first meeting on the 7th of October on behalf of Simon and Healthwatch Worcestershire to really come together for the first time and to set the scene and the approach and the process for how we would start to begin to develop a draft strategy for Herefordshire and Worcestershire. I caveat that with the fact that we need to do that draft by December, which is a very protracted and kind of national timeline. So therefore we've had to make some compromises, but I'm going to share the approach that we've taken with you. The purpose of the Joint Committee is to really to bring the local authorities into the heart of joint working around integration with health, social care and broader statutory and non-statutory partners. I always find this a bit difficult because I'd like to list everybody, but I can't. So hopefully that's a reasonable set of terminology around that one. I think it was a really positive discussion and a positive start, and kicked off a first and second phase of engagement, which I'll talk about in a minute. So on the next slide, I just wanted to bring us back again to the Health and Care Act and to the sort of 4 statutory duties or strategic pillars that integrated care systems have now got as kind of statutory partnerships. And you'll recognise these, and you'll see that in the work across Herefordshire and Worcestershire in the system space through sustainability and transformation partnerships, and all of our kind of collaborative structures that we've been working around this. But I think it's really important to reflect that the fact that the strategy is about how are we going to deliver these 4 strategic pillars across Herefordshire and Worcestershire, working in collaboration, working through our collaborative partnerships that we've already got in place. So in Worcestershire, that's Worcestershire Executive Committee, the district collaboratives, the primary care networks, the VCSE Alliance, plus. So it's about using those kind of existing structures and forums to work to deliver this better, more efficiently, and to make those improvements. So the 2 kind of pillars on the left-hand side are arguably the most important around that collective aim. So improving outcomes in population health and healthcare. And I always like to draw out the fact that it is the broader population health and the healthcare, hence that much closer relationship with the Health and Wellbeing Board, its subcommittees, and around the delivery of the joint local health and wellbeing strategy that's just been ratified, hasn't it, by the council, I think, this week, and that primary and subsidiary focus under that. Tackling inequalities. So as Sarah said, we've absolutely got to work proactively to reduce disparities in outcomes, experience and access. And we've got some really good examples of proactive work that's happening across Worcestershire and Herefordshire around that. But this really puts that at the heart of actually how we look at improving, developing, transforming pathways. And that's where that relationship with the VCSE and community providers is so important, isn't it? Because they have a much closer relationship with communities and understand their needs arguably more effectively than some of the statutory partners. So it's balancing the kind of the data, the information, and that broader experience. And then up on the right-hand side, we've absolutely got a finite financial envelope across health and social care and local authority. So therefore, we're committed to enhancing productivity and value for money, and looking at driving out duplication, being more efficient, sharing data and information in an appropriate way, and hopefully making that a more efficient and experience for the patient or the service user as well, in terms of what can I access, how can I access it, what's the difference it's going to make. And that was a conversation that I heard at the community partnership in Herefordshire yesterday, in terms of just making what's available to people kind of clearer for them to understand, using communicational channels that works for everybody. So that might mean we need to look at kind of multiple areas, so demystifying some of that. And then on the bottom right hand side, this is it is a partnership, but this is a particular duty that's been put on the NHS about working in that broader economic and social development. So in the way with our role as anchor institutions, and working with communities and thinking about the wider determinants in a more strategic way than we might have done historically. So that's the why we're here and why we're doing this piece, essentially. Okay, I'm going to move on to the next slide, which, apologies, is a little bit smaller. Inevitably, we've been gifted some national guidance around the development of the strategy, and I just wanted to share that with you on a page. And there's a couple of points I want to pull out here, really. So it's really helpful. It gives us kind of permission within systems to develop the strategy in the way that we need for our local communities and population. And what it does is it ensures that we put the joint strategic needs assessments at the heart of the strategy. So this is around those much broader population health needs as well as those healthcare needs. So then when you look at the list on the left-hand side, you'll see the kind of good practice, best ways of working about how we're going to do that. And I think I'd want to pull out here the importance of prevention, and getting serious around prevention. Personalised care, again, a really important agenda, which is about improving access and outcomes and experiences for all, understanding people's differences, and designing health and care pathways around those. And really using, as I said, data and information and analytics as effectively as we can to plan, commission and deliver health and care services around people's needs. I think it's really positive at the bottom there to see the importance of an all age focus, focusing on children, young people and families. And what the guidance does is asked us to think and recognise the impact of kind of health and care needs of adults on children, young people and families as well. So again, looking at it from a more holistic approach. So what we're doing in our strategy in Herefordshire and Worcestershire is looking at those good practice, best practice guidance, and looking at the areas where we want to work together to develop new approaches or to solidify and spread some existing good practice that we've got in those areas. And that's where there's a real opportunity for learning across the 2 counties. Okay, thank you. I'll move on to the next slide, which is the timeline and approach before I come to the structure, and then share my kind of open questions and listen to what you have to say and what you're seeing and what you're hearing. So first Integrated Care Partnership Assembly, 7th of October. We're meeting again on the 14th of December to review the draft strategy. It will be a fairly short document compared to some of those that I've written. For those of you who know me from the kind of system development space, I think I managed 200 pages with the system development plan. So this strategy, I'm committing to less than 30 pages. I'm trying to hit 20. And it's really important to me that reflect on the fact this is going to be published. So this is going to be a publicly available strategy for people who live and work in Herefordshire and Worcestershire, and also who work in health and care services. And I think that's really exciting, and there's a really important opportunity there. But it's about making sure, therefore, that the language is in plain English and it's accessible, and that it means something. So what we're doing is taking that draft through the Assembly in December, and then we'll be taking it out from January to March publicly for some much broader conversations with public and communities around whether it's right, whether it works, whether we need to change anything in there, and to really develop the more granular ambitions around that, with a view to publish that in April 2023. So I'll now go back to the bottom of the slide and talk about, okay, so within that contracted time frame, how are we going to approach this in the best way that we can? So we framed a kind of phase 1 engagement, which I hope will give us an opportunity to put communities and citizens and patients' experience about where things are now and how they need to be different in the future in terms of integrated working and improving outcomes and reducing disparities at the heart of the strategy, without being able to have taken the time to go out and talk to people during this period between October and November. So Tom Grove, who's our Director of Communications and Engagement for Herefordshire and Worcestershire, has been working with the network and with yourselves to look at existing engagement over the last couple of years, and to really do a thematic review of that, to look at what those themes are, about where are things now and how do they need to be different within those kind of good practice examples. And what we plan to do is to put that in the heart of the strategy, because we want to put people at the centre of it. This strategy for me is really about building a better vision for the future for people who work in health and care and people who access health and care and broader wellbeing and prevention services. So that's the sort of phase 1 approach, and there will be a report available. It might be something that it would be really helpful to test with yourselves and to share with you. So I make that kind of question invitation. And then the sort of phase 2 engagement, which is running alongside, really takes that broad membership from the ICPA, and we put out an invitation to kind of colleagues there to go out to kind of yourselves, collaborative forums and groups, sectors, and to ask these open questions, which I'll come on to shortly, to really get the views from people, so we can put that into the writing the strategy, rather than come out straight out with a draft to say, what do you think of this? So what you'll see, I hope, is a positive and subtle change in the way we've approached developing this strategy. And obviously we'll be testing that and reviewing how we think that's worked. But that's where we are. And then the third phase, as I said, which is to take that draft out January to March, to really test it and push it, and to look at those priorities and those ambitions, and where we really want to go harder and faster together to make those improvements where there's opportunities, using those existing collaborative forums. Okay, and then if it's okay, Joe, I'll just quickly do the kind of structure. I'm conscious of your time. Is that okay? Because I think it's probably helpful for you to get a bit of a feel for, okay, what's this going to look like? How is this going to be set out? So we've pulled together this slide. So if I start with the purple box, top left in box 1, we want to document kind of population need from an experience point of view, as I said, with the phase 1, from a data point of view, but looking at public health, population health data in the joint strategic needs assessment, looking at where we are in terms of health and care performance, and really getting a rounded needs assessment to set the context for the strategy. And you know, some of that is about understanding where we are as individuals and citizens, and where we are as organisations and partners post-pandemic, with the inflationary increases and the cost of living. So, as I said, a more holistic kind of needs assessment. The second piece is about mapping together kind of collaborative strategies and plans that we've already got in place to deliver those, go back to those 4 aims, those 4 strategic aims. And I think that's going to be really valuable already. It's been really helpful to actually look across the 2 local authorities, the NHS broader partners, and say, what have we already committed to? And then we'll be doing a mapping to say, how do those align? Are those all pointing in the same direction? Do they lead us to think we might need to look at a particular area to work together? And then actually, just as a function in the ICB, myself and my colleague will be kind of holding those as a bit of a repository for system partners. So if you're looking at developing your strategy or your plan in one area, you can come to us simply and quickly and efficiently and say, actually, what's already out there? What do I need to be mindful about? So that's a really basic thing, but an area where we want to add value to support collaboration in an efficient way. And then if I go down to the bottom of the slide with the orange and yellow, this is about that broader partnership and those broader health and wellbeing needs. So the health and wellbeing strategy in Worcestershire will be at the heart of that kind of Worcestershire section, and the Herefordshire Health and Wellbeing Strategy is currently under development and out for consultation. Another timeline kind of flux challenge. So they're sort of where they are at the moment will be in the draft strategy, and then what we'll be doing is looking at that, looking all of that in the round, standing back and saying, are there any other requirements out of that list of good practice guidance we would want to aspire to? Are there any areas where we can work better together, kind of quicker, more efficiently, and to really move through to a phase where we can prioritise those areas we want to work on together. So that's the broad kind of structural approach. And then I will pause there if it's okay, Joe, for any clarifications, because I'm conscious I've landed a bit of content on you this morning. And then we'll move to my kind of open engagement questions for you, and I shall do my listening bit. Thanks, Joe.
Thanks very much, Ali, and thanks very much, Sarah, as well. Yeah, that's really it. And anything we can do to help, obviously. You said about reading, the engagement report and anything, you're very welcome. Do we have any questions? Can I see everybody? We got any questions? Oh, Brendan. You're mute. Sorry, Brendan.
Yeah, thanks so much for these presentations. I'm a declared fan of collaborative and integrated working. I've been doing it all my professional career, and I do see that there's been positive progress across both Hereford and Worcester over the recent years to ensure that that's a reality. I engage very closely with lots of groups. I'm on an ICS program board, and I'm also on various other boards. But I engage with the people at the front line of the services where they either are or aren't. And I include patients, the public, and also include staff. I've had a significant engagement with staff over the past 3 months, and I fully appreciate the need to have strategy 100% to have a vision 100%, to have ambition 100%, and to have creativity. The difficulty that I see at the moment is when it comes to things like prevention, and I've been involved actively for years in active prevention, like suicide prevention, like stroke prevention, and various other things. But the reality is, and I'm sad if this comes across as a deflationary observation, there are so many things at the moment that need to be addressed, because many of the aspirations that you have for the future and you've outlined in the pillars, etc., don't exist at the moment for many people. So how can you assure the people that I speak to, and I'm including staff, I'm including patients, I'm including carers, and including quite often people that don't have a lot of hope at the moment, that this strategy is going to start working effectively and visibly and tangibly for these people, many of whom fall into the categories of those who have an inequality in terms of either access or provision or receiving an opportunity for better outcomes. Thank you.
Thank you, Brendan. And Sarah, did you want to come in before I do?
Yeah, I can come in there. I mean, it's a difficult one to give sort of full assurance that the strategy will deliver what it says, and that's why all the engagement work is going on. But I echo what you're saying, and that absolute tension between meeting strategic objectives and the sort of the tyranny of the urgent and what must be done now for people waiting, and to balance that with the work that intuitively and research based, and from the work that that you've done, we know the prevention element has to happen. So good news is that prevention and personalisation do feature really heavily in the proposed strategy, and that's, I'm sure Ali can capture some of that in terms of the engagement and what's been said. What I am pushing for is that we will have, as far as the health inequalities elements there go, that we'll have a few system-wide reportable measurables that we can be held against. And that's really, really important. So we'll know whether the work we're doing is going in the right direction. As you will also be aware, some of those things don't happen overnight, and we don't see an improvement in the data for a few years. But there was an interesting thing I read today. The World Health Organization say that 60% of contacts with healthcare services are related to lifestyle and preventable issues. And so if we don't start to work downstream with those things, then we're never going to be able to meet the demand. So hugely important.
Yes, Brendan, you wanted to carry on.
If I might come back, I won't be assured, but I can understand the tyranny as you've suggested. But if I come back to the preventable stuff, I waste a lot of time dealing with certain organisations within the system who basically think about preventing the preventable and say, oh, we need to go back to this stage in life, or we need to do this and we need to do that and the next thing. Please be assured that the areas that I'm involved in, particularly stroke prevention, and have been very actively involved, suicide prevention, again, very actively involved. It's about quite often secondary prevention. And please remember, I'm sure you do, that we all need to take the steps in terms of secondary prevention, because often, as I say, I waste a lot of time with certain organisations that think that virtually the whole answer is primary prevention. Absolutely important for the longer term, but secondary prevention needs to be a clear and deliverable prospect.
Thank you. The next, I've got sort of 4 people up. So I've got David Trigger next, then Jonathan, then Lee, and then I think it's David Saunders. But Dave Trigger.
I'd like to echo everything that Brendan has just said. I completely agree with that, but I'd like to take it a step further. 22% of the people that live in the ICS area have a disability. And I feel that looking at the strategy as it's been presented this morning doesn't show that there is an acknowledgement that of the special needs of those with a disability. I'm an NHS England patient leader. I'm also a member of the West Mercia Police Independent Advisory Group on Disability. And we can see that when it comes to planning services, those special needs of people with disability are not taken into account. I'm also concerned about, we're not talking about co-production. Co-production is where everybody that has an interest is involved in the decision making. And there is actually a statutory requirement for patients to be involved in the planning of services, but we're not seeing that at the moment. And I would like to request some comments, please, from Sarah and Ali as to how we see the way forward on that. Thank you.
Don't mind, Ali, if you, I'll briefly say something and then you kind of comment from your perspective. I mean, I'd be really interested to take that further and potentially offline, just conscious of time, but which services do you feel there hasn't been? Because I mean, that's a clear issue as a non-exec that I'm really interested in. Which service planning and provision don't you feel there's been public and patient engagement in? And it may be that the statutory duty has been met, but that actually that hasn't been done in a way that's left people feeling that they've been engaged. And I think they're 2 slightly different things. In terms of co-production, that is entirely sort of what the ICS is about, and the Integrated Care Board being made up of all our statutory partners, so NHS, local authority, and all the NHS providers, including primary care networks. And then overarching that, we've got the Integrated Care Partnership, which does have that wider partnership member. And on their responsibility is to approve this strategy. So that is a co-produced strategy, taken the wider public engagement, but co-produced and approved at that ICP level, which does have partners there. But if that isn't coming through clearly enough, or if there are sort of obvious things that you think are missing, then this is the time for Ali to capture that. So I think she's delighted to capture those things in more detail, because we want this as much as you do to be, you know, co-produced and co-delivered.
You asked for an example of where, just a simple example is the Dementia Strategy Board, which has no representation of people with dementia in terms of patients or carers. So right at the beginning, we asked that we get representation across the board. It's all very well having organizations such as a VCS that has that knowledge, but there is a mandate for patients to be involved at all levels of service planning, and I don't see it. Sorry, Sarah.
Well, no, don't apologize. It's hugely helpful for me to hear that, and to, you know, to explore that further with you. That's really, yes, there's often that fine line between a VCS representing people and patients and the patient and or carer in that circumstance voice. So yeah, I'm happy to explore that further. Thanks.
Thank you.
Joe, can I just add on the co-production point? Because Ali, I don't think
I
picked up when you mentioned it, but it was raised at Health and Wellbeing Board with you, wasn't it? At the development day, and you gave a very positive indication you'd be including a direct reference to co-production.
Absolutely, Simon, thank you. Shall I come in? at this point. So as Sarah said, what you're doing is actually answering my two open questions. So I'm just going to pitch those out and then I'll come back to the topic because you're already doing it, which is great. So thank you so much. One is actually what do you want to see in the strategy? And the second one is what needs to be different, or how does this need to be different? Because this strategy is about kind of learning from the past, building on the good, understanding the not so good, and then building that into a better future and some commitments across our broad range of partner organisations. So we have an ICS level communications and engagement strategy. If we need to do more to pull out a co-productive approach, and I've seen it when it's done well in my time in the kind of trust provider side of things, and that's where there's a real opportunity to deliver those 4 pillars in the right way and to put people's needs at the heart of this. So absolutely, we will be including a commitment in the strategy and kind of unpacking that and understanding what that needs to look like based on what we hear from different groups and sectors, and you're not the first group of people to pull it out, which is great because it supports the need there in terms of what we're going to do. And with the ICB as well, as kind of Sarah probably talked about at the beginning, it's a much broader membership in terms of the partner members there as well. So actually, how is this going to be different? We have got different opportunities here because of what the Health and Care Act has given us, and we want to deliver on those. So yeah, absolutely committed to putting the right words in the right way. And a bit of feedback I've had around the strategy, and again, when we get to the draft stage, I'd really welcome your input around this, is to put kind of co-production and community voice kind of throughout the strategy, rather than just putting it on one page, which might what we've done historically. So again, I need to think about how can we do that kind of so that works, and so we make those commitments. So I think it's really helpful in any of the questions and responses during this discussion, Joe, if people can think about putting forward what do you want to see and how do you want this to be different. But I've certainly made lots of notes around that, so thank you for bringing that up.
Thank you, Ali. I think the next question was from Jonathan.
Thank you both. I've got a couple of questions for Sarah and a couple for Ali. It's worth saying that I come from a kind of position of, okay, then we've got a new structure imposed upon us. It's not perfect. We might have done it differently. It's probably an undeniable truth. There isn't enough resource to go around. So we need to come from that position. Let's do the best we can. Let's not take sniping shots at people. So that's the position I come at. So I'm enthusiastic and share your enthusiasm to get this right. Sarah, the 2 questions I have is, where does the buck stop with responsibility and accountability for health services in Worcestershire? And the second question is, what resource will be apportioned to what I would call the deep battle, the deep prevention work, the primary prevention work, if you will, that Marmot might have talked about? So there's 2 questions there. Where does the buck stop and what resource? And then I'll come to Ali's question.
So the buck stops, it's a convoluted sort of governance question, but the buck stops with the ICB for the meeting the constitutional requirements of the ICB. However, the provision of services and liability for provision of services sits with the provider organisations that provide them. So it's slightly, the hospitals have standards which they must meet and are held accountable for, and the Integrated Care Board pull together a set of metrics that they report to NHS England for which they are responsible. Over time, I won't spend too long on this, but over time, the hope had been that some of the commissioning function that was held centrally in an integrated care system was devolved to places, so Worcestershire, and they had if you like, a Worcestershire budget and provided services. And there, the accountability for delivery would still sit with the ICB, but liability for what happens at provision would sit with the providers. So a slight sort of difference between the two. But ultimately, I think as an ICB, loosely taking aside the legal issues, we as a combined board have a corporate responsibility that the services that are provided to Herefordshire and Worcestershire are the right ones and deliver. So, but individual organisations still have their own, which is trying to fit a round peg in a square hole with the way that the legislation is formatted at the moment. So I'm hopeful that the legislation is a staged process and things will change over time to meet what is needed. Your second point, I'm really cautious to ever use the word marmot out of Coventry. So I chair the Coventry Marmot Partnership, absolutely would buy into wider determinants of health, notwithstanding secondary and tertiary prevention when it's needed, but working upstream at primary prevention, especially working with people in the very early years of life and those wider determinants. So I think the only assurance I can give you is that already I'm becoming a minor irritant, raising those points and questions at the board and looking at how we actually shift the resource from the actually liberate and shift the resource to that. So I'm part of the strategic commissioning committee at the ICB, which has made a commitment to prevention and to holding that as a question we ask whenever we commission a service. It's going to be difficult. It's going to require other champions across Worcestershire from a variety of organisations and people being on board with that. But it is something that I personally am very on board with.
Thank you, Sarah. Thank you for the answer about governance. That's the best explanation I've had in 2 years. I think I'll definitely credit. So, Ali, turning to you. So you asked what should be in the strategy, right? That was your question. And as you said that, I wrote it down. I think we've got to first be clear about what we mean by strategy. It's one of those words, isn't it, that's used as if it sort of sprinkles sort of magic fairy dust on what could be a pretty average plan. And it's not used necessarily how it should be. It comes from the Greek stratus, doesn't it? Meaning what? General. So let's use it correctly. I will read the strategy through the lens of ends, ways, and means. That's the simple way I look at it. What's the ends? How are you going to deliver those things, and with what resource, what means? But then there are kind of three acid tests of whether it would be a good strategy, I think. Does it set medium to long-term aims? Does it commit significant organizational resource to the problem? Is it difficult but not impossible to change if we change our minds? And are there clear priorities? Because strategy amongst anything is about choice, what you can do and what you don't do. And are we clear about those choices? Or are we going to fudge them and make everything a priority? So that's what I'll be looking for, and I'm looking forward to reading it.
Thank you very much for that. I think that's really helpful. I love the way that you kind of distilled that, and I will take that away in the way I'm kind of reflecting and writing. It resonates with what I want for this. The strategy needs to be visionary, but then we need to work together to deliver it. And I've certainly kind of committed to this being around a smaller number of priorities that we really outcomes-based priorities that we really work on together. We have multiple layers of complexity across health, social care, broader statutory, non-statutory organisations, don't we? We have, as I sit here, we have one population. Yes, they live in different communities, different counties, so forgive me for saying that, but actually this is about those people and actually how we work together to improve improve things for them. So thank you for that, and I look forward to your
You're
review
welcome.
of the draft and your challenge back around that.
And it's a supportive review. I'm not getting at you, but I've read so many documents in the last 9 years that have a local authority or a government stamp on that says strategy, which is, you know, should be prosecuted under the Change Description Act for use of the wrong word. They don't make any sense. Thank you. Thank you both.
Thank you. I think the next person was Lee.
I suppose it's for Sarah and Ali. It's more of an observation and a comment. It's just going back to when strategies are formed, where that intel comes from. And as a VCS member, as well as being a co-opted member of Healthwatch, I am also on the Alliance and on the Redditch District Collaborative. So I do feel things have started to move more positively. So again, this is from a positive position, but we still have to remember though that historically we've been through new ways of working. You know, I've been here 20 years, so this isn't the first time we've been in this situation. And I just think you still need to remember when strategies have been formed and that intel's been collected, to make sure that that is evidence from a broad reach of people, and not just, I think health a lot of times use the same people repeatedly for that pathway of data or intel. A perfect example of how I feel it sometimes doesn't work. A needs analysis, a needs assessment was done in Redditch for domestic abuse by the Redditch district. And when it was doing that, it used the data capture from the police statistics in Redditch and also the Redditch Borough Council's involvement in DA. No engagement was done with the VCS whatsoever. And if you take away West Mercia, Women's Aid and RASAC, we're the largest deliverer of domestic abuse services in North Worcestershire, and yet we weren't asked for any information at all to feed into that assessment. So how accurate was that information that came from district that formed then into county services? So I just feel like, yes, things are moving positively, but I think we still need to remember that and make sure that there is some overview and scrutiny, that health doesn't slip back into old ways of working, of just using the same pathways, that it is open to making sure that it works very closely with the Alliance and districts, and doesn't, but actually not just relying on the Alliance, it's making sure they're open to all engagement and not just sticking to any one pathway.
Thanks, Lee. So are you going to respond to that, Ali or Sarah?
Shall I come in, Sarah? Thank you, Lee. I think just music to my ears, and I think that's a really good point about actually using the existing collaborative partnerships at mechanism in terms of feeding that intelligence and that understanding of communities and their needs up and down, you know, and across those structures. I think we've tried to embody that in our initial approach to the conversations for the strategy. I've certainly been to a broader set of partners that I've been to before, kind of open to developing that onwards. But I feel what you said actually needs to convert into a commitment in the strategy about the way we work together. So thank you for pulling out that particular detail.
Thank you. I think it was David Saunders next.
Thanks, Jo. Thanks both of you. That was really interesting. I think a lot of what I was thinking has been covered by David and Lee, really, just to make sure that that report fully integrates with all the voluntary services that are available, because I think they tend to get left behind quite often, and there's an awful lot of both enthusiasm and talent and experience there that's you know, a real goldmine of assistance and guidance. So it's Ali really to add that into her report, I think, or assuming it's already in her report.
Okay, thank you, David. Chris Byrne next.
Yeah, hi. Yes, I too look forward to reading the strategy. What I wanted to particularly pick out was the areas bigger than the Hereford and Worcestershire ICS. So I'm looking at regional cancer networks, specialised commissioning, and also, of course, the staff shortages that we've got across the NHS. So I'm be interested to understand how the ICB will influence upwards outside of Hereford and Worcester. Thank you.
But I can leap in quickly, Ali, but feel free to, sorry, from your director perspective, sort of overstep what I'm saying. But from my understanding as an ICB member, sort of the influence in upwards, hugely important. Our chief executive sits on a group that is a group of the West Midlands lead other chief executives working together to add a bit of power and size to comment to NHS England regionally. We work really closely with NHS England, and I am being positively assured by the relationship that the ICB chair, Krishni Waring, has with colleagues at NHS England. A really strong relationship, but one where she's able to bring our system nuances to their attention, but speak quite a lot of truth to them. So she's not someone that's afraid to sort of speak truth to the power. So that gives me a degree of confidence. Interesting you talk about specialised commissioning and some of the wider services. So that will be coming to the ICB. So the ICS will be, the plan is that we will take on specialised commissioning from NHS England. The plan, so we take on, the ICB will take on responsibility for optometry, dentistry and community pharmacy from April of next year. And then the specialised services, so in terms of some of those transplant things, those really rare and tricky things, the plan is we'll take that on board the following year, but with a year working towards that. But again, please be assured we are regionally, the ICBs are asking questions and are not wanting to take on something that is not going to be beneficial to the people on the receiving end. And so a good amount of due diligence and readiness and question asking is going on there before we feel that we're in a place to take that on. And we'll see how that develops. Also, you didn't mention mental health, but that sits alongside sort of cancer in terms of regional alliances. And we've got really strong voices there with the Mental Health Alliance. I know that we're seen as a really strong voice there and a very good kind of provider and speaker into that. So yeah, I think conscious that we are a big part in Herefordshire and Worcestershire, but a small part in a much bigger system. And
exactly, yeah. And I think, you know, I would like to hope that there's some strategy from that point of view in your plan as well, so that, you know, we don't drop the ball in terms of just focusing internally, which is really important, obviously, but there's a bigger picture here as well, isn't there?
Right, thank you very much. Did you want to add something, Ali?
Thank you, Joe. I just wanted to add in terms of the workforce piece. So Chris, it's really helpful that you've kind of opened up the conversation around that one. A huge challenge, particularly in certain professions and areas in terms of across health, social care, and broader than that. So we have this will be a priority in the plan, because we have been building joint working, close working across Herefordshire and Worcestershire in that workforce space. So where can we add value? Where can we work together? And there was a first Herefordshire and Worcestershire ICS drop-in kind of health and care recruitment event at Worcester Racecourse yesterday, which was hugely well attended. There were some interviews, kind of jobs were offered, and I think from my understanding, I dropped in at the end of the evening yesterday, kind of coached loads of school children, attended, people from the university, people from colleges, people from different areas, kind of on their kind of career journey, some at the beginning, some further down. So that's just an example of actually where we're working together. We had partners, providers there, and just going out into the community there to give people an opportunity to do that. We're also working as an ICS footprint on the redistribution nationally of training places, so away from central London and moving them out. So working very closely with the university. There's been a conversation this week at the People Board for Herefordshire and Worcestershire about actually what's the attrition rate for nurses once they finish training. So they're doing their placements in Herefordshire and Worcestershire. How many people are staying? How many people are leaving? Why? What can we do? What can we work together to put in place to improve that retention rate? So there's a few examples of some of the things we're doing, but it's a key area, and it's one of the new duties that the ICB has that the CCG didn't have. And you'll see within that in our structures, and with the inclusion of Katie Hartwright, who's our Chief People and Workforce Officer, who sits in the ICB. So I think it's exciting, and it's starting to look at real practical opportunities of how can we make a difference in that kind of retention, recruitment and broader space. So an absolute core focus for us as a system, and we'll be seeing that in the strategy, because without the people to deliver the services, then we can't deliver those better outcomes, can we? So thank you.
Thank you very much. Thank you.
I'm conscious that we're rather overrunning here. I've got 4 more questions on the board, and that's it. Okay, Julia, would you like to just ask your question?
Yeah, just quickly. First of all, I wanted to follow on from Jonathan about accountability, because recently I've been pushed from person to person trying to improve the mental health services, and it was really helpful if you could have one person who was accountable. Otherwise, you're just going around in circles. And secondly, talking about co-production, the NHS is historically a hierarchy of workers, and it really needs to think about co-production. I've recently read some of your paperwork on co-production from your engagement team. It's very poor, and I'm having a meeting next week. And you, being such a national large company, you really need to get your head around it properly.
Okay, thank you. Sarah, would that be appropriate for you to just respond to that, or is it Ali?
So I can respond and say, keen to listen to those observations. Really helpful to hear when people don't think we're getting it right. So thank you. In terms of co-production, I think that's the point sort of that you're raising again there. And as you've heard Ali say, that's really the aim. The ICS, it's hard to get our heads around, but the ICS is an integrated care system. It is multiple partners working together. So by default, it is people working together. But happy to take that on board and see that done well. That's our intention. So when the draft comes through, if there's anything specific you'd like to add, I'm sure Ali would take that on board. But when the draft comes through, please do, red pen it and send it back with comments. That'd be helpful to us.
Okay, thank you.
Thanks, Sarah. Pete.
Yeah, I would like.
You're mute. Sorry, Pete.
Yeah. Just to say, having been involved with the Alliance and with the emerging ICS, ICB, etc., I think it's a really good start. But the only thing I would say is that I haven't been around for many hundreds of years around co-production and certainly child and young people's voice. It's really important that voice is actually driven from the young people themselves. So we've been pushing. In fact, I think the ICB and the ICS have started very well in terms of listening, probably without being too rude, much better than the individual organisations. So certainly with the County Council at the moment in Worcestershire, it's quite hard work to get people to understand what co-production means. So I have been very heartened by what both the Alliance through Esther is on the call, but also the ICB itself is doing. So more power to your elbow, and just keep doing it and just keep fighting for that voice to come across, particularly for the minorities who are still, 1 or 2 people have mentioned this, who are still isolated.
Thanks, Pete.
Right, thanks. And I'll just jump in there without putting too much burden on Ali, but I think we sometimes miss a trick with schools where we've got captive groups of children who could give us very feedback we might not want to hear, but feedback that is really pertinent and to the point. And often schools do gather their brightest and best to come to feedback sessions, so you may not hear the true representative, but at a school assembly, when I've done those, the feedback you get there is particularly blunt. So
and we've got some really good examples of how we're engaging with schools, and that's my point about the ICB are already listening to us in terms of using that methodology. And as you say, for somebody who's passionate about minorities, I'm not just interested in the head boy and the head girl. We're actually working with young people who are out of education, whatever else, because we've got the staff to facilitate it. So any of that we can help to get that, well, it's not right to say, but the real voice, absolutely brilliant. But good start.
Thanks, Pete. Bernie.
Right, sorry, I was jumping around the screen then, so I couldn't unmute myself. Yeah, just a couple of comments. Firstly, yeah, I agree actually with Pete that the ICB are doing really well at co-production from now on. It's sort of it's taken a long time to get to this level, but actually it's starting and it's happening quite quickly. So I've seen much more improvement in the mental health co-production and different services in terms of disability, children with disability and special educational needs. So that's one positive thing, far better than the council, which has still taken them a long time to get on board with. Just on the point of children in schools, I want to just highlight, obviously, those children with SEND who aren't in school, whether or not that's because they've got an education outside of school in their EHCP plan, or whether or not they're just off with heightened anxiety and are unable to attend school. So those are the voices that actually we really need. But then sort of without wanting to duplicate work. So I just want to highlight, obviously, as a strategy, this is like an overarching strategy for everybody and everything. And of course, we're aware that that's the little strategies that are existing beneath. So obviously, one of my main focuses as the various different things, the Autism Partnership Board Chair, for example, I'm the lead for that. And, you know, the autism strategy is a huge part of that. And the LD has got their own strategy and everybody has different bits and pieces going on. But I am conscious that when there is a strategy that exists, say, for autism, that then it's sort of absorbed into a plan like this, and then it maybe doesn't go any further. So I'm conscious that, obviously, like I put in my comments, autistic people, we access all of the services that anyone else will access. So we're not one little cohort, really. We're actually a massive community that needs addressing. And I think in this strategy, because it is such a big partnership of different organisations, we really need to really bang the drum for that understanding of individual needs and what a bespoke service actually looks like without being too draining on resources. So obviously, reasonable adjustments, they're not just what one person might consider a reasonable adjustment, it actually has to meet the need. And I think whilst an autism strategy exists, there might be a risk of not including these sorts of barriers to accessing health. And of course, from my position, and I've kind of said this quite a lot recently, that we're familiar with the leader reviews and reviews into the deaths of learning disabled, and obviously now that includes autistic people too. As a strategy for an entire integrated care service, I would really like to start seeing a bit of digging deep into that prevention that we were talking about earlier, and how do we not get to the point where we're having to do a leader review on someone because it's gone too far too late, when we should be preventing far earlier. And those stories are available, but we just don't analyse them in the same way until someone's died, which is really, really a shame. And I think that in particular with autistic people, all of these different services are so much more difficult to access. And we just need to keep thinking about that in terms of health inequalities. And that's children, adults, family carers, everything kind of comes into that. So it's a bit of an observation, a bit of a champion in terms of co-production, because part of my role is existing because I'm a champion and engaging with autistic people and my voice is being heard. But we need to go out to those that aren't in my position, as well. We keep needing to feed out. So, thanks.
Thanks. That's really useful point to hear. Really, really positive. And I think some of the challenge and the way that we work over time will be not doing that duplication. And actually, if part of your role as speaking to people who are speaking to people who are actually hearing the voice firsthand by the ICB is really important, but actually for the whole breadth of the population, that there's always someone that's missed out, but it's actually how we work together to capture and to sort of distill those voices without filtering them too much and making them fit what we think they said. And last very quick point just is about what you're talking about is this personalization point that Ali talked about. I love the concept of personalization, that your care should meet you and should ask the question, what matters to you? Not what do I think is wrong with you as a doctor, but what matters to you. However, I think Jonathan raised the point, there are finite resources and we need to work out where there are boundaries to personalisation. What matters to me might actually not be within the gift of the NHS to provide. And so how we, again, make those two things work is a bit of a conundrum that I think we're going to need to work on together.
Thank you, Sarah. I was muted. I think that was the end of the questions. Ali, did you want to then leap back into your presentation? I'm conscious that we've gone a bit baggy, but I think it has been valuable input for you. So I hope you have found it valuable, but I know you've got a couple more slides, haven't you?
Thank you so much, Jo. Thank you to everybody who's kind of reflected on the questions and kind of shared your views with Sarah and I today. I don't need to put any more slides up. It was just the open questions which I sort of threw in because I could sense that we were going to go. You were going there anyway, following my presentation. And I think there's lots for me to reflect on. I've made lots of notes and align with what I've heard from various different kind of sectors and groups and partnerships. I think that the challenge for me and colleagues will be how we cover the breadth and depth, as you say, with this kind of overarching strategy. And therefore, I think what I've really heard from you today, which is great, is actually how do we need to deliver. And actually, therefore, I think the strategy will need to focus on that. And Bernie, thank you for just shining a light on that area of focus for us. And my final reflection would be, in terms of that context setting and the strategy, we've got to balance where we're starting from and where we want to get to in kind of year one, and that balance between a strategy, a strategic plan, implementation, and then review. But it's all about being outcomes focused around that. So thank you very much. And Jo, if you're happy, I can come back, or a colleague can come back kind of with the draft. Obviously yourself or Simon will be with us on the kind of 14th of December, so able to have a look at that from an early perspective. And if there's anybody on the call who thinks you've got a sector or a group that would want to feed into this process, whether that's between January and March, probably now, then I'm really happy for somebody to share my email address, etc., or kind of go through Simon or Jo. So thank you really. Lots to reflect on. I really so much value in the room. Much appreciated.
Thank you very much, Ali. And yes, that would be great if you come back to a later meeting. That would be really valuable. And I think we've wrapped up. I think we've finished the questions, and I'd just like to take this opportunity to thank you, Sarah and Ali, for coming along to our meeting. I think it's been incredibly interesting and hopefully very valuable as well. Thank you very much.